welcome you all today's class on mitral regurgitation. That's an important class actually, because there is always there may be a short, long case or even a short case of mitral regurgitation in your final prof examination. Mitral regurgitation is a very important short case as well as also long case. And it is also important for written examination as well as short questions. So we'll discuss today on mitral regurgitation, and this discussion will definitely based on some case-based as well as there may be some evidence that can provide the evidence for management of the patient with mitral regurgitation. So let us start mitral regurgitation. This is the first case. A 32 years old lady presented with shortness of breath on exertion, increase in intensity for last months. On examination, she is dyspneic, pulse 105 per minute, regular blood pressure normal, respiratory rate 28 per minute, systolic 3 lead apex, S1 soft palpable P2 component of the second heart sound is loud, and pansystolic murmur in the apical area with radiation to the left axilla. ECG is sinus tachycardia. Chest X-ray showed there is a cardiomegaly. An echocardiogram showed severe mitral regurgitation with moderate pulmonary hypertension, and patient being treated with mitral valve replacement, and she is doing well. So what we learned from this case report, that there is a 32 years old lady. So as rheumatic heart disease, as we know that rheumatic mitral stenosis and mitral regurgitation, this may be a sequelae of chronic rheumatic heart disease. As there's a sequelae of the rheumatic fever or a complications of the rheumatic fever, so usually female are more predominant in case of mitral stenosis, like mitral stenosis, in case of mitral regurgitation also females are predominant. And patients, how actually a patient with mitral regurgitation presents, and this, like this lady, patient may present with shortness of breath on exertion. So shortness of breath on exertion, this is the commonest presentation of a patient with mitral regurgitation, but patient may be asymptomatic even in the mild cases. So patient in mild to moderate cases, patient may be asymptomatic, and patient may be symptomatic only on exertion. And when there is a advanced mitral regurgitation like moderate to severe mitral regurgitation or severe mitral regurgitation, patient usually presents with shortness of breath even in rest, or patient may have shortness of breath only on exertion, and that increases in intensity for maybe increasing in intensity over the time actually. So this is an important findings how the patient usually presents. So patient may usually present with shortness of breath on exertion especially, and even patient may present with complications also, like in case of acute mitral regurgitation. Even patient may present with heart failure, features of heart failure also. So in ECG shows sinus tachycardia, chest X-ray, there is a cardiomegaly due to mitral regurgitation, and obviously echocardiogram is the gold standard investigation by which actually we can diagnose the mitral regurgitation, as well as we can assess the severity of the mitral regurgitation. And we also assess the condition of the valves also actually, and that actually offer us which treatment actually a patient of mitral regurgitation is needed. So, and in this patient, this young lady, mitral valve replacement was done, and this patient actually was doing well. So mitral valve replacement is one of the modalities of treatment. This is a definite treatment also in a patient with mitral regurgitation. Obviously, in a patient with symptomatic mitral regurgitation, that is moderate to severe mitral regurgitation with pulmonary hypertension. So this is the first case, and this is the second case. Like the first case, this case is a little, the patient is a aged patient, 55 years old lady, presented shortness of breath on exertion for the last 8 months, increasing in intensity for the last 1.5 months. She had history of CMC 20 years back. So what is CMC? Closed mitral commissurotomy. What is closed mitral commissurotomy? Closed mitral commissurotomy is a modality of treatment of the mitral stenosis actually, and it is a surgical procedure. And by surgical, this procedure CMC, actually we do, there is a enhancement of the mitral valve area, that is to increase the mitral valve area. This is the procedure. There is a commissurotomy actually, and by doing the commissurotomy, we usually do to increase the mitral valve area. And Ishta PTMC 10 years back, and after doing CMC, she also needed PTMC after 10 years. PTMC is also a procedure, that is the interventional procedure, percutaneous luminal mitral commissurotomy, and with this procedure, actually we do. It's also commissurotomy procedure, but not is a surgical procedure, that is the intervention procedure. And in that cases, how commissurotomy is done? In that cases, commissurotomy is done by balloon inflation. Actually, there is a inflation of the balloon, and this balloon causes the rupture of the chorda, actually rupture of the commissure actually, and there is a increase of the mitral valve area actually. So PTMC done 10 years back, and on examination she is dyspneic, pulse 118 per minute, irregular, blood pressure 90/70 milliliter mercury, respirator 32 beats per minute, diastolic 3 in the apex, S1 short, P2 loud, mid diastolic murmur in the apical area, based on the left lateral position, basal in expiration, and pansystolic murmur in the apical area. There is a two actually murmur, one systolic murmur, and there is also diastolic murmur. So there is a both mitral stenosis as well as mitral regurgitation. ECG shows atrial fibrillation. As we know that long-standing mitral stenosis or long-standing mitral regurgitation can lead to the development of the atrial fibrillation, as there is a increase in the size of the left atrium, and this increased left atrial size can be lead to the development of the atrial fibrillation. So there is maybe a atrial fibrillation, maybe a complication of the mitral stenosis or mitral regurgitation also. Chest X-ray view shows there is a cardiomegaly, the extending of the left border, double right border. Echocardiogram shows severe mitral stenosis with severe mitral regurgitation with severe pulmonary hypertension with Wilkinson score 13. Patient underwent mitral valve replacement, and she is doing well. So actually, what we learn from this case scenario, we learned that this is a aged patient. As this aged patient, she has actually several operative as well as intervention procedures before. What are the procedures? CMC and PTMC, these are done 20 years and 10 years back. So these are the two procedures already done in her mitral valve. And now this patient has mitral stenosis as well as mitral regurgitation and severe pulmonary hypertension. So as the valve is damaged a little bit more, so this patient actually offered the treatment of mitral valve regurgitation. Now this time is the treatment is mitral valve replacement. And Wilkins echo score, already I have discussed what is Wilkins echo score in the previous lecture. This is the actually scoring scoring procedure, that is Wilkins echo score, by which actually we see the condition of the valves, actually mitral valves, and to see actually the feasibility of the commissurotomy, actually PTMC. If Wilkins echo score is less than 8, then the PTMC is more feasible, and PTMC results are more better than Wilkins echo score if more than 8 actually, or more than 10. So as the patient has got Wilkins echo score 13, that is valve condition is actually worse. So this patient actually offer mitral valve replacement, and mitral valve, after doing the mitral valve, the patient is actually doing well. So this is the two case report. In both cases, with mitral regurgitation in one cases, and one mitral regurgitation with mitral stenosis with pulmonary hypertension, and in both cases, actually the final management procedure is mitral valve replacement. So mitral valve replacement may be an important procedure, important management procedure in case of mitral regurgitation. So something about the mitral regurgitation. This valvular heart disease occurs when heart valve fails open or close properly. As we know that in case of valvular heart disease, there is two types of valvular heart disease. There is actually mitral stenosis, and there is a stenotic type of ablation, and there is a regurgitation type of ablation. Stenotic type of ablation means there is a valve area actually is reduced, so there is a reduction in the opening of the mitral valve or any valve, and so there is a obstruction in the flow of the blood flow from the one chamber to the other chamber through this stenosed valve actually. So stenosis means there is a narrowing of the valve, and there is maybe regurgitation, that is also called, there is a leaking of the valves actually. So regurgitation type of lesions. So there is two type of lesions, or there may be mixed lesions also. That is, there is a stenotic type as well as there is a regurgitant type of lesions of actually, and there may be two types of lesions in together. So as we all know that there is actually what is the function of the valve actually. So valve maintain one-way blood flow through the heart. The four heart valves make sure that blood always flows freely in a forward direction. There is no backward leakage. There should not be a backward leakage. But if there is a valve deformity, that can lead to the development of the leakage of the blood through this valve, and that is the regurgitation type of ablation actually. So here we see that there is a four valves. There is a pulmonary valve, there is a aortic valve, there is a mitral valve, and there is a tricuspid valve. Here we see that this is the pulmonary valve, this is the aortic valve, this is the mitral valve, and this is the tricuspid valve. So this tricuspid valve, the tricuspid, there is three cups, there is a two cups, and aortic and pulmonary valve, there is a semilunar valve, there is a three actually semilunar cups, there is a three cups there. So now what are the parts of the heart valve actually? As we know that this is the actually leaflet, and annulus or leaflet, posterior leaflet. This is the commissures actually. This is the chorda actually, and this is the papillary muscle. So there is actually three parts. This is a leaflet, this is the chorda, tendineae, and this is the papillary muscles. So abnormalities may occur in anywhere of the these valves. So there is a deformity in the, or there is involvement of the leaflet, there may be involvement of the chorda tendineae, or there may be involvement of the papillary muscle. So lesion may occur in anywhere, and this may lead to the different types of regurgitation lesion actually. If there is a rupture of the papillary muscles, that can usually occur in a actually traumatic condition. There may be a trauma due to some procedural during some procedures within the valve or within the heart. There may be rupture of the papillary muscle, or the papillary muscle can be ruptured in a following mitral infarction. So in the mitral infarctions, there may be rupture of the papillary muscle, and that may lead to the mitral valve dysfunction, and there may be mitral regurgitations. So a chorda tendineae may be involved, or a leaflet may be involved in case of rheumatic process. So there is maybe thickened of the chorda tendineae, or there may be thickening of the and also shortening of the chorda tendineae and thickening of the leaflets can occur, and that may lead to the development of the mitral regurgitations. So this is the part, this is the annulus, this is the commissure, this is the chorda tendineae, this is the papillary muscle. This is the commissure actually, this is the leaflet, annula, this is the annulus, actually annulus, and this is the leaflet, this is the commissures, and this is the chorda tendineae, this is the papillary muscle actually. Annulus actually is the fibrous ring-like structure. Commissure, the site of union of the corresponding parts. Chorda tendineae is the thread-like structure that connect the actually this connects the leaflet with the papillary muscle. And the papillary muscle, this is attached, usually it is a part of the ventricular muscles. These are the some protrusions, like there is a nipple-like protrusion from the ventricle within the ventricular cavity. So this is the abnormal valve function. Already we have discussed. There may be valve stenosis or valve regurgitation. There may be combined condition also. So what are the actually valve causes of this valvular disorder, or what causes can lead to the deformity of the different valves like mitral valve, aortic valve, tricuspid, pulmonary valve? And that's maybe due to some congenital causes, but the commonest cause is the rheumatic heart disease, or rheumatic involvement, or rheumatic fever. That is the commonest cause of that can cause the deformity of the valves, or that can cause the deformity, thickening or deformity, or that can cause the damage of the heart valves. The commonest cause is the rheumatic heart disease, and then congenital heart disease. There may be infections like bacterial endocarditis. Even there may be myocardial infarction that can lead to the damage of the heart muscle, as well as there is the papillary muscles also. There is a weakening of the supporting structures of the heart. The types of valvular heart disease, there is a on the class that classified on the basis of duration of dysfunction. That's acute and chronic. There may be natural valvular dysfunction like stenosis or regurgitation type, or there may be degree of dysfunction that depends on the actually the NIHA degree of cardiac dysfunction. That causes a NIHA shortness of breath classification. That is stenotic type ablation that causes the obstruction of flow from the blood from one chamber to the another, and there is a regurgitation. That means there's a leaking of the blood. That is, there is a leaking from the one chamber to the another chamber. So what are the investigation actually we do to diagnose a case of mitral regurgitation? History is actually important, and in case of mitral regurgitation patient, usually give history of shortness of breath on exertion, but in case of mild to moderate mitral regurgitation patient may not have any symptoms. Patient may be asymptomatic. And physical examination, already we have discussed. Patient may have tachycardia, patient may have thrill, or patient may have murmur in the apical area that may radiates in the axilla, axilla. ECG usually sinus tachycardia may be seen, or patient may have atrial fibrillation. And chest X-ray, there is a cardiomegaly actually. There is a stenting of the, maybe the stenting of the, there is associated with the mitral stenosis, stenting of the left border. There may be right border also. But in isolated mitral regurgitation, usually we see there is a cardiomegaly. Echocardiography, the gold standard test, echocardiography and color Doppler study, by which actually we confirm the diagnosis of the mitral regurgitation, as well as we can see the condition of the mitral valve, and we can also categorize the, or we can see the Wilkins-Echo score, and by doing Wilkins-Echo score, we can actually assess the feasibility of the medical management actually. And by we can also see the severity of the mitral regurgitation also. That can help us to correlate with our diagnosis, as well as that may help us to help us to what are the management actually we should offer to a patient with mitral regurgitation. And there may be some invasive investigations like the, angiogram or cardiac cath. There may be CT and MRI may be needed to confirm the diagnosis of the mitral regurgitation, or if it is a part of the congenital heart disease, in that cases, CT MRI is very much helpful to diagnose the other actually associated anomalies, as well as to see the mitral regurgitation conditions actually also. So there may be congenital heart disease, that is, there may be bicuspid aortic valve that is a cause of the aortic stenosis, as well as that may lead to the development of the aortic regurgitation also. So ischemic heart disease, rheumatic fever, hypertrophic related cardiomyopathy, or there may be aortic disease like Marfan-Ehlers syndrome that can causes the mitral regurgitation also, as like aortic regurgitation. So patient, in case of mitral regurgitation, patient may have symptoms of heart failure or low cardiac output. As we have already discussed, patient may have shortness of breath on exertion, even patient may have chest pain or discomfort, or patient may have syncope due to low output syndrome, or patient may have fatigue, or peripheral pulmonary edema and palpitations also. Patient may have tachycardia also. And on examination, as I have already discussed, patient may have murmur, actually apical murmur, systolic murmur that can be started with in the left lateral position, and then maybe radiation into the axilla, or even we may get the systolic thrill also, and apex width may be shifted due to the cardiomegaly actually, and there may be features of heart failure also, because acute MR is a common causes that can lead to the development of the acute left ventricular failure. This is the actually mitral regurgitation. There is a murmur actually due to mitral regurgitations. Actually, we see pansystolic murmur. And ECG that is actually non-specific, and we can also diagnose we can also find sinus tachycardia or features of left ventricular hypertrophy, as there is a leaking of the blood through the valve that causes a volume overload over the left ventricle, or there may be features of the left ventricular hypertrophy. There is a left atrial enlargement, atrial fibrillation, bundle branch block, or there may be a presence of any type of arrhythmia like atrial fibrillation or any type of ectopic beats. On chest X-ray, the commonest finding in case of mitral regurgitation is cardiomegaly. Usually we get there's a cardiomegaly, or even we can see in chest X-ray that is mitral valve calcification, or if there is a prosthetic mitral valve replacement, we can also see in X-ray actually. And by we may see the failure of the heart features of heart failure like pulmonary congestions due to mitral regurgitation. This is the echocardiographic findings. Actually, mainest of the valve disease, diagnosis follow. This is the actually gold standard investigation that can diagnose the mitral regurgitation, as well as we can see, or we can do the severity of the mitral regurgitation also. We can also assess the mitral valve condition. So these are the some investigations that we have already discussed. There may be CT, aortography, CMRI, MRI. We can actually, or cardiac cath we can do actually. This is the causes secondary. So already I have discussed this. So this is the this is about acute mitral regurgitation. So acute mitral regurgitation is very much important in the clinical scenario, because in the ward we see in some conditions we can get this acute mitral regurgitation. Usually that occurs following there is a myocardial infarction, and that causes the papillary muscle rupture, and that may lead to the development of the acute mitral regurgitation. There may be papillary muscle rupture, or there may be cord rupture, but papillary muscle is common. And there may be infective endocarditis can also lead to the cause of mitral regurgitation. But the commonest actually cause that we usually encounter in the cardiology cath lab actually, that is the commonest cause is the balloon actually overinflation of the balloon, or during PTMC. As a complication of the PTMC procedure, we can get the mitral regurgitation. There is actually commissural rupture or the over, and this causes the acute mitral regurgitation, and this is a fatal condition. And usually we get patient with severe shortness of breath even during the procedure or just after the procedure of the PTMC in the cath lab actually. And this patient is in that case is immediately shifting to the CCU. CCU management is needed. Even in that cases, acute urgent mitral valve replacement can be needed actually in case of acute mitral regurgitation due to the commissural, that is actually commissural rupture, or due to actually complication of the PTMC procedure. And acute mitral regurgitation actually always present with acute left ventricular failure, features of acute left ventricular failure. And this is another term, mitral valve collapse. This is actually congenital condition. In that cases, usually we get mitral regurgitation with mitral valve collapse. Patient may be asymptomatic in the most of the cases, but in some cases, if the collapse is more, in that case, a patient may have symptoms like fatigue, shortness of breath, dizziness, syncope, palpitation, chest pain, and anxiety. And in case of mitral valve prolapse, when you auscultate the patient with mitral valve prolapse, you can get there's a mitral click, and that is a systolic click. And we can also get the mitral murmur actually. That is the mitral regurgitation murmur, features of mitral regurgitation murmur. So what are the management actually in case of mitral regurgitation? So already I have discussed in 2 cases that the mitral valve replacement is the actually treatment, main stay of treatment of mitral regurgitation. So prosthetic mitral valve or biological valves that are actually available and that we can replace with the native valves, and mitral valve replacement is the ultimate answer in case of severe, moderate to severe mitral regurgitation actually. So this is the metallic mitral valve, and the metallic and the tissue that is tissue biological valve. There is 2 types of valve actually, and that actually we replace with the native valves. Actually, this important thing is we should know that in case of valve replacement, when there is a mechanic mitral valve replacement, in that cases we should always just anticoagulant the patient with warfarin actually, or any type of anticoagulant. Anticoagulant is necessary in case of valve replacement. In that case, usually we kept the INR in between 2 to 3 in mitral valve replacement cases usually. So this point is important when there is a prosthetic mitral valve or metallic mitral valve replacement. In that cases, usually we anticoagulant the patient in always actually. But in case of biologic valve replacement, it is not necessary that the patient should be anticoagulated. And this is actually INR for the mechanical mitral valve. Actually, we do 2 to 3 in between 2 to 3 actually mitral valve. So this I think we can stop here today. It is all about the mitral regurgitation. So we have discussed through 2 cases mitral regurgitation, and we have also discussed the cause of mitral regurgitation, the presentation of the mitral regurgitation, or how we can diagnose a case of mitral regurgitation, what are the investigation we should do, and what are the management actually we should offer to a patient with mitral regurgitation. So in case of mitral regurgitation, the main treatment option is the mitral valve replacement. So I think we can stop here today. Stop sharing.